Today we have the privilege of having Professor Roxana Mehran, who's Professor of Medicine at Icahn School of Medicine at Mount Sinai, New York. Welcome, Dr. Roxana.
It's nice to be here. Thank you.
So tell us about your, association with India Life. We've seen you, the India Life has grown with you over a period of time. So how has it been?
Yeah, India Live has been the last 14 years, almost 15 years, has been the go-to meeting, I think, here in Asia. I've had the privilege to be at several of these meetings over the years and have learned so much. But most importantly, not only is the content fantastic, the academic level extremely high, you get to learn about all that is being done here in this wonderful country in terms of interventional cardiology. And the progress is absolutely unbelievable. The last 14, 15 years that I've been coming here, I have seen the progress, the incredible skills of the interventional cardiologists here. We learn from you all. And it's been a fabulous, fabulous meeting for me. Not only am I learning, but I'm using this as a fantastic way to network with my colleagues. This meeting attracts so many people from every part of the world. And it's a testament to the quality of the meeting and the important impact it has around the globe. So thanks for having me. India Live is really alive and well, especially after the pandemic. This year, I'm amazed of the enthusiasm from everyone in the audience, the excellent questions, the interactivity between not just the panelists and the chair people, but also the entire participants. They all have the chance to come up and ask any question. And everyone is welcomed and included. And I love that about this meeting.
Great. So tell us about your talk yesterday about the antiplatelet strategies in high bleeding risk patients, because that's a very difficult substrate of patient.
Well, thank you. That's a talk today that I'm going to be talking about, and I'm really excited about it. I think, the dilemma of which antiplatelet therapy in whom for how long is something that's extremely difficult to do because not one size fits all. And there's so many different drug combinations in terms of the duration, the type of drug, the setting, that you can get extremely confused. And while the guidelines are there to give us guidance, they don't tell us exactly and prescriptively what to do for individual patients. So lots of this is really culminated into understanding the risk profile of our patients, whether they're at high bleeding risk or high ischemic risk, and finding ways to balance that. But importantly, is a lot of overlap, and that's where it becomes more difficult, and that's where the novel approaches come forth. And especially in high bleeding risk patients where we have to de-escalate our antiplatelet therapies, whether it's going from dual therapy to a single antiplatelet therapy, preferably a P2Y12 monotherapy, certainly to avoid bleeding without increasing ischemic harm, especially in ACS patients. And then in other areas is just de-escalating the potency of the agent, going from ticagrelor to, let's say, clopidogrel. And the biggest one, I think, that has been having a huge impact, and it takes a while for us to get used to something that we've had forever in our armamentarium, and that's aspirin. And aspirin-free strategies are really, really up and coming. It just takes a while for it to really get traction, but I do think it's a fantastic way forward. We have so much data now in certain select patient groups where we could really modulate the antiplatelet therapy and navigate this with our patients early after intervention, intermediately up to 1 year, and then beyond. And I think that's the part that's very exciting for us to think about over the next couple of years. And then I talk a lot about what's to come in the future. And factor XI inhibitors are around the corner. Large-scale trials are ongoing. One of them was just stopped in atrial fibrillation for lack of efficacy. The DSMB stopped, but I still believe with the right dose in the right patient, there could be a way forward where there is less bleeding and preserving the ischemic benefit in a potent fashion. So I'm excited about that as well.
So we were talking to David earlier, and he suggested that because there is a stent in place, and that thrombosis is one of the reasons that you need these antiplatelet agents. So having no stents there, like using drug-eluting balloons or even scaffolds which dissolve, is it going to change the approach later on?
I think early post-intervention you could be more free to de-escalate your antiplatelet therapy. So I think for high bleeding risk patients in whom you could get a fantastic result in the right setting, I don't think drug-coated balloons are for everyone, but in certain settings, diffuse disease, small vessel, all of that, you could get away with less antiplatelet therapies, especially dual antiplatelet therapies, and reducing the duration, although none of that has been studied prospectively.
It's all intuitive as of now.
But I think we have to think that a lot of these events happen even with patients on dual antiplatelet therapy. So we can't stop thinking about beyond antiplatelet therapies as well. And that what I'm talking about is bringing that LDL low, looking at the patient's hemoglobin A1C, controlling diabetes, especially in a country like this where diabetes is ubiquitous and extremely prevalent. And then, of course, seeing if there are inflammatory biomarkers in whom where you really do need to be very cognizant of risk factor reductions. And then with that, all of that, I think we'll be able to do less with antiplatelet therapies and more with other therapies to really, really help our interventions get better. And I think one of the things that we kind of forget about in interventional cardiology sometimes is we're so focused on the procedure that we believe that, well, the doctor will take care of it on the outside. But if we don't dictate that right from the cath lab, it just never gets done the way it should. And so we should take accountability in caring and optimizing the medical management of our patients. So as with drug-coated balloons, I do believe it's an interesting way forward, but remember that a lot of these events occur outside of the lesion you're treating. That lesion is literally few millimeters of the blood vessels that are all the way across. So there's not just cardiac, but extracardiac atheroembolic disease that is associated, or peripheral vascular events, limb events, stroke events. So antiplatelet therapies do a lot of good for those events as well. So we've got to be thinking outside of our love, which is, doing the procedures and thinking about the patient as a whole.
Great. You've been a great scientist, and you've been involved with so many other trials as well. Could you give us a small peek into what you're doing now and what's there in the future?
I'm really excited about some of the trials that I'm involved in. I'm very fortunate to have the ability and the interest. First, I'll say that everyone who's listening should up their game by getting into clinical research, because it really is, we as cardiologists work so hard with the evidence that's in front of us, and we should continue that kind of a high-level academic and clinical trial work that helps our patients get better for their outcomes. And I think so that's really, really important. So I'm involved in several clinical trials. The ones that I'm really excited about will be presenting 2 late-breaking trials with the groups that I'm working with. One is on an ApoA1, synthetic ApoA1 injection or infusion in patients after a STEMI or after acute coronary syndromes with high-risk features. So that's a CSL 112 infusion, and we're very, very excited to take a look at that. That was in almost 18,000 patients, so we'll be looking at that patient population. The other one that I'm very excited about is the SMART trial, which is the very, very first randomized clinical trial between two commercially available valves, a balloon expandable valve platform versus a self-expanding valve platform in patients with a small annulus. So over 700 patients enrolled and followed for a year, and we're going to be looking at clinical endpoints, but also very, very important hemodynamic effects on the valve and valve dysfunction over the year with very, very good follow-up on their echoes. So it's very exciting, especially when you think about, you think about a way to include more women in your clinical trials. Think about something that is more prevalent in women, like a small annulus.
Yeah.
So we'll have lots of women in that trial as well. So it's exciting. So those are the two trials. And then, of course, I'm involved with a large-scale diabetes study where we're looking at two different stents technologies. One is the everolimus-eluting stent, and the other one is a sirolimus-eluting stent, which is an abluminous stent. We're very, very excited about that as well, and 3,000 diabetic patients over the next year. And then, of course, very involved with factor 11, as well as an IL-6 inhibition, which is going to be first coming out, a trial where we'll look at IL-6 inhibition, which is going after inflammation in patients with high C-reactive protein after a STEMI or a non-STEMI in our patients, new therapies beyond antiplatelet therapies, and so many more. So lots and lots of good stuff coming down the pipe.
That's very exciting.
Yes, lots of good stuff. Yeah.
Thank you very much for being here.
Well, thank you so much for having me, and congratulations on this fantastic meeting. And all the audience, don't miss India Live. It's a great place to be.
Thank you.
Thanks.
Insights from the world's best medical minds. You are watching TheRightDoctors.com.